Hello. Today we'll be talking about something a little bit different. CRM, that's Crisis Resource Management. Uh, I'm Guilherme, I'm an emergency physician, and this is a concept that maybe you're not familiar with it, but it's very important for emergency medicine. So, when we're thinking about practice, most of the specialties, the medical specialties, you can just grab a computer, an office, put your stethoscope on the neck just to look like a doctor, and see your patients. You don't necessarily need a team. Yeah, of course, usually you have one, but sometimes all you need is just an office, a practice, and you're good to go. But when we are talking about emergency, that's not the case. Emergency medicine is a team sport. We have to put order in the chaos. We are every day dealing with chaos, stressful situations, a lot of unpredictable stuff, and our job is to put order in this chaos and do the best for our patients. But how do we do this? So, this is the concept of CRM. It started with cockpit resource management. Uh, a lot of people saw that planes crashed because you have a pilot, a co-pilot, and they wouldn't talk to each other. They would fight, and decisions would go bad, and accidents would happen. After that, the companies started doing trainings for the pilots and co-pilots and how to communicate effectively. After some time, they saw that it's more than just the pilot and the co-pilot. There was a very emblematic accident here in Brazil. It was a flight that was going in the rainforest, in the Amazon forest, and there was a passenger that's seated on uh, one side of the plane. He called the flight attendant and said, "Hey, I take this flight every week. I get seats here because I don't want sun in my face. So that's why I choose this role. So every week I'm on the shadows. And this week I have sun in my face. So something is off, something is wrong." The flight attendant went to talk with the pilot and co-pilot, and they were like, "Yeah, I am the pilot, I'm the boss, I know what I'm doing." And a couple of hours later, the plane crashed in the middle of the rainforest. Turns out that the pilot put the autopilot instead of putting a course like 030, put 300. And instead of the plane going one side, was going to another side, and they missed the direction and fell in the woods. So they realized that it's not just a matter of pilot and co-pilot, it's a matter of all the crew. Several companies realized that this kind of training of communication skills were important. They brought to the corporate resource management. And for us in the medical community, we use the concept of crisis resource management because for us, every critical patient is a possible crisis. We have to deal with this to avoid bad outcomes. So what it is. It's the non-technical skills needed for effective teamwork in crisis situations. So we are not talking about how to intubate, how to get a central line, or do CPR or like hard skills. We are talking about soft skills, pretty much communication, how to communicate effectively in a crisis situation. It's a bit different from our every day-to-day chit chat. We have the Swiss cheese theory that accidents happen. That we have several barriers for an accident not to happen, like slices of Swiss cheese. Each one has holes, and you have like several slices, but every now and then the holes will align, and one accident will happen. So how do we avoid this? Either we make the holes smaller or we get more cheese slices. So they realize that when planes crashed, and we can extrapolate this data for medical, 70% of the accidents or the bad outcome is due human error, and out of that 80% are due bad communication. So pilot and co-pilot not talking with each other effectively, and that kind of stuff is what brings planes down. And in medicine it's the same. It's ineffective communication is bad for your patient. So we have to have more barriers on more effectively communication so we don't have bad outcomes. And we can think about that as the seven denominators of disaster. The first one is an unfamiliar environment. That happens a lot. You're going for a new job, you change station, you change the hospital, you finish your residency and is going to work in a new place. That happens all the time. So what do you do? Well, you have to know your environment. One way to do it is we have crash cards pretty much everywhere in your ED, in your ER, in your floor. But more importantly than just knowing that you have a crash cart is, well, I have a defibrillator. How do I turn it on? You know, how do I use it? And what do I have in each of the drawers? You may get a checklist because, at least here, nurses love to put lockers on it, and sometimes you are not allowed to open it and check it. So you have to get the checklist. But every now and then, it's important for you to know what you have in each drawer and how to use your equipment. So when a patient is coming, you don't waste time. Another thing you have to do is test your stuff. It's not the moment to realize that your laryngoscope blade is not working when you're trying to intubate, or that your BVM has a hole in it, or something is not working properly, or you don't have it. You have to test it when you're working in out of the hospital in pre-hospital. Usually we check it. When you start the shift, you get your bag and check everything. It's more routinely, but for the inside the hospital, we don't have this mentality of checking every time you start your day, which should be the norm, not the exception. And also, you have to know what extra resources do you have. Like, do I have a guru on the top of the mountain that if I need, I can call him to help me? Who is this guru? Do I have it? Yeah, sure. Well, maybe I can call him. Another denominator of disaster is lack of prepared preparation. The first one is personal skills. Personal skills you learn beforehand, doing courses, taking courses, classes, watching videos, having hands-on sessions, and whatnot. This is you are actively searching and getting better at your job. So you have to do this before the patient arrives, before you arrive in your shift. Another thing you can do is anticipation and planning. One thing I like to do is thinking, okay, if I have a potential bad patient, what can go wrong? And if something goes wrong, what can I do? What's my plan A, my plan B, my plan C? For instance, if I can't intubate, do I have LMA? Can I crike? Or what else can I do for this patient? I have to have other options. And one concept that we can bring both from the aviation as well as from the military is the concept of briefing. When you start your shift or before the patient arrives, get your team, talk with them, know who is who, and okay, who is going to do what. The patient we are expecting is this, so John, you do this, Mary, you do that, and you have this before. You can do this in the beginning of your shift if you know your team, and it's a very important part of the day and of CRM is the concept of briefing and get your team talking the same language and everybody on the same mind state. Another possible thing that can go wrong is the delay for asking for help. So you need to know what help can you get. You know, can I ask for the crash cart? Do I have a guru? Do I have someone that can help me? Do I need to call an ambulance for an interfacility transfer? Uh, what resources do I have? And especially, how can I get it? You know, can I just shout in the corridor for the crash cart, or do I have to call? Have I have to call? What's the number? You know, this kind of stuff is really important when you're thinking about asking for help. But the most important is to call for help. But the moment you realize that this is beyond your capacity or could be, call for help. Call for anesthesia, surgery, or whatever other resources you may need. It's really important not to waste time and call beforehand or as soon as you realize you need help. And you can have inefficient communication. This is really critical. One way to mitigate this is using the three C's. That means citing names. When you're talking with your team, it's very helpful to have name tags so you can know who is who and call by the name. Give clear orders. So it's no time to use fancy words to show that you know stuff. No, you have to be clear. People have to understand you. And a very important C is the closed loop. So if I ask for something, I have to be clear, and the person that I'm giving the order to should give me the feedback and say, okay, I understood you want this, and that. And once the order is done, give me the feedback and close the loop and say, hey, the drug is in, or whatever procedure is done. So I know that I gave an order, the order was understood, and the order was done. So the loop's closed. These are the three C's, and they are very important when talking among your team. Also, another way to improve your communication is what I like to call hive minding. So talk what you're thinking so that everybody, all your team know what you're thinking. Okay, what this patient has, what will be our next step, what I'm thinking. If the patient doesn't respond to this, we'll have to do that. And you have to talk this out loud so that everybody can be on the same page and anticipate the next steps. When you're asking for a drug, use name, dose, and route. So if you want AP, ask for 1 milligram of epinephrine IV. So, and the other person will say, okay, I'll give 1 milligram of epi IV. And once the epi is in, hey, epi 1 milligram is in. That's the closed loop. Also, very important are the constructive interventions. So, when we are dealing with the patient, it's normal to forget stuff or sometimes miss stuff, do some mistakes, and that's why I say this is a team sport. All your team must be comfortable to give input for the team leader and say, hey, shouldn't we do this? Or, well, we can we do this? Last call, we had a similar patient that was somewhat like this, and we did this and it worked. So, of course, it's the team leaders, the final decision is up for the team leader, but all the team should talk and give these kind of interventions. And another thing is define a vocabulary. Uh, there are some places that some specific stuff have different names. Some drugs can be called adrenaline or epinephrine. Some tests can have different names, and when using brand names, this can be an issue. So it's very important for you and your team to have a similar vocabulary. That's especially important if you are moving to a new place and people use different words for the same stuff. So it's something that can cause mistakes. And also you have to remember that a team of specialists is different from a specialist team. Google did is they studied, like, they have several work groups, or and some work very well and solve the problems and some don't. They just don't work. And they studied why this happened. And what they saw is that it doesn't matter if you get like the biggest brains, the best people with the biggest curriculums, and put them in a team. If they don't communicate efficiently, the team doesn't work. So it doesn't matter if I get my all my best specialists and put in the ED to see a critical patient. If the communication is not working, you need a good team with good communication for a good outcome. Another problem we may have is the lack of situational awareness. This is also a very important issue from aviation, and we must focus on what's more dangerous, not that's not always the what's getting all your attention. So sometimes we have this, uh, we just focus on something and forget the rest. For instance, oh, it's time to get an ETT in. I'm going to intubate, and the patient rests, or I don't know. But I'm so focused on this intervention that I forget the big picture, and that's a very important issue. One thing we can do to stop this is take a deep breath and take two steps back and say, hey, where are we, and what can we do? What are we missing? Take a good look around and hey, let's see the big picture. Stop focusing on just something. And that's what I said. What are we missing? We are missing something. And get your team with you and hey, what else can we do? Did we forget something? Can we get another drug, another intervention, call somebody else? Especially if things are not going the way you want to go. So always take this two steps back and ask yourself, ask your team, what are we missing? This picture I really enjoy. I really like it because you can see the team leader is on the feet of the patient and is the only one with the arms crossed. So in a best case scenario, the team leader is someone that's not putting his hands on the patient, is just taking care of the scene, seeing the big picture, and pretty much like a maestro conducting the orchestra. He's not playing any instruments, but he's seeing the big picture and making everybody play the same tune. That's the job of the team leader. Another problem we may have is some uneven workload. Our When we have a critical patient, we should see it as a Formula One pit stop. You know, everybody knows their job, their equipment. You should know your team. You should know what resources you have. This is a very important issue. If you have like that one person you really trust in your team, and you start giving all the orders to that person because you know he or she is really good and will do the job very well. But the problem is that you have to have all your team involved. You can't overburden this person and forget about the others. You have to distribute the tasks. So we must think like a pit stop, each one doing something at the same time for the patient. And the last of our denominators of disaster is the lack of leadership. So when you're thinking about the team leader, he or she must be calm, have control of the situation. If you see some team leaders screaming, shouting, probably he's not a good team leader. You should have like sometimes you need to call your attention of the team for you, but when, especially when the energy in the room is to the roof, you have to, hey, everybody, look at me, let's calm down, let's take a deep breath. But that's the only time you shout. If you're shouting orders and everybody's screaming, the odds are against you. Also, the it's the job of the team leader to make the decisions. Interventions from all the team, everybody can talk, but the responsibility and the decision making is the task of the team leader. For this, the team leader must keep always the situational awareness. If the team leader is focusing on something, he's losing the situational awareness, and that's really, really bad. And the team leader should be a Swiss knife, should know the job of everybody. It doesn't mean that uh, if I'm the team leader and I have that nurse that worked 50 years in an ICU and couldn't get an IV, it's not me who will get. But I must know that if we can get an IV, what will be our next step? If the someone is doing the chest compressions and they are not good, it doesn't mean that the team leader has to go there and start CPR, but must be coaching or sometimes asking for the change. And I must know what everybody should be doing and how to coach or what the next step should be. And that would be our disaster denominators. And one thing that I really find interesting is this concept of the 0 point survey. Usually we teach the primary and secondary surveys, and this is a survey that comes before you see the patient, and it should be the step up. So we are thinking about the self, the team, the environment, the patient, updating, and priorities. There is a QR code for the one of the studies that's pretty good. Talks more in depth about this concept. But what we are thinking about the 0 point survey is that when I'm thinking about self is before I'm seeing the patient, do I have the best conditions to do the best for this patient? Am I up to the task? Uh, I'm safe. So do I have any illness that is rendering me ineffective? Am I using any kind of medications, drugs? Uh, have I drank any alcohol? Am I tired? Should I eat or go to the bathroom? This kind of stuff is really important for us to see the patient. And this would be our physical well-being. Also, we can think about our mental well-being. So take a deep breath, talk with your team, sometimes talk with yourself, see the environment, and focus on the upcoming patient. So this is a way for us to see if okay, can I give my best? And should we change the team leader? Can it be me? Am I up to the task? Yes. Okay, let's proceed. After that, we are going to talk about um, the team, but we have when we're thinking about stress and we are talking about crisis, we have these situations, the our conditions. Condition white is like when you're on vacation, you're all good, relaxed. Condition yellow is when you start your shift. You're not seeing any patients, everything's calm, but you're already in a higher state of alert. You're ready. You know that at any time uh, a crashing patient may come. Condition orange is when this patient comes. Your heart rate starts increasing, uh, your adrenaline starts pumping, and you can go from orange to red or gray. In situation red, you start losing your fine motor skills, so some thing may be harder. For instance, getting a central line, getting a tubing, that kind of stuff can get harder because you start losing your fine skills. But on conversely, your mind is rushing, that can be good, and like uh, some other complex motor skills like CPR can be better. This kind of stuff, your body is getting prepared for this fight or flight situation. But if your stress keeps growing, you get on condition gray, and your complex motor skills are also degrading. And if you're in black, you have like completely ineffective. You can do anything. So you should just leave, because now you're a liability, not an asset anymore. And when we're thinking about the team, we should always, that's pretty much our briefing. You should have like a clear team leader who will be in charge of the situation, assign the roles for everyone on the team, and have another briefing before seeing the patient low. Just a quick update on what we are going to do, what will be our next steps. The environment you should check. That's something we tend to do a lot of in the out of hospital environment. We don't usually do this on the in hospital, but here in Brazil, sometimes this can be tricky, because you have to see if there is any apparent danger. Usually the hospital is a controlled space, but the space, do I have enough space to see my patient? Sometimes we have crammed rooms, and you can't literally you don't have enough physical space around the patient for you to do the interventions you need. Do you have enough light? Is there too much noise? This is a problem. Sometimes even the team can be noisy, and you have to lower the voice, lower the temperature of the room. And the crowd is also a problem, not just lay people. Sometimes even the medical team, if you have too much people in the room, people that are not contributing, they should leave. Just leave around who is actually doing the work. There are some hospitals that have a circle around the bed, and just people inside the circle are allowed to talk. So this is a way to mitigate this problem of the crowd, but it's not everywhere. And once the patient arrives, this 0 point survey become the primary survey, and we'll do the X, A, B, C, D, E, and start like actually surveying and evaluating our patient. There's a very interesting paper was done in the Iraq-Afghan war, where surgeons and anesthetists doing combat surgery, damage control surgery, they would have a checklist where every 10 minutes the anesthetist would stop and say, hey, it's been X minutes since surgery, and the surgeon would say, okay, we are doing this, the next step is that, and we are planning on doing this and that. Okay, and every 10 minutes they would update, and not to lose track and not lose situational awareness. So this kind of update is really important. And also it's a way for refocus the priorities. So okay, we have updated, we are 10 minutes, 20 minutes, half hour in. uh, what are our goals? What are we expecting for this patient? And how are we going to reach these goals? What will be our trajectory? So this is the 0 point survey, thinking about, uh, am I in condition of seeing this patient, preparing my team, preparing the environment, actually seeing the patient, updating the status of the patient, and rechecking our priorities and how to get the best for this patient. So okay, we had our crashing patient. We did everything we could. Either we stabilized him or eventually the patient died. But anyway, the case is over. Case closed. We have now order in our chaos again. So now what? I just tap on my back and said, "Hey, it's all good. Let's go home and have a beer." We can have a very important thing that we did our briefing in the beginning of the shift, just before the patient arrived, and now we should, or we, yeah, it's good practice doing a debriefing. So we should have a facilitator, not necessarily a leader, could be a team leader. This team leader, this facilitator, it's very important for him to assure psychological safety, make everybody comfortable, saying, "Hey, okay, everybody that was working this patient, let's get together. This is an opportunity for us to talk about what we're feeling, how was the case, and to improve. We are not here to point fingers or finding mistakes and find guilty. No, we're here to improve our care for the next patient." So should start with a shared mental model, like sum up the case. The patient was this patient, we did this, and that, and this happened. And we should have rules and objectives like uh, we are here to see what we did, how we were feeling, and what we can do better, or what we did good. And that would be the objective of this debriefing, and the facilitator should make this very clear. So a few things, a few questions the facilitator can use to guide the talk is like, what happened? And this is a way for an intro to give a quick summary of the case. How are we feeling? And for people really, yeah, this is annoying me, this is not, I'm really happy, I think this is what was a really case, we aced it. Or yeah, I don't know, I don't like this kind of case, I'm feeling bad. The Is there anything annoying you? Why? It's very important to know why we are feeling this. Sometimes we need this opportunity to get extra help, and it's really important to ask, what have we done well? Because we always have done something right, even if it was a shit show. Something was good, and we have to know what this was so we can grow on that. But also, what could we have done differently? This is an opportunity to improve the care for the next patient, because we are here not for ego or not for money or whatever. We're here for the patient. That's our ultimate goal. So doing all this we are doing to look for trying to get good outcomes for our patient, for the ones we are caring for. And that's the goal, getting the best care for this kind for our patients. So what could we have done? It's a question for what can we improve for the next patient. Usually there's something we can improve, and it's important to remember that meant is not said. Not everybody is a mind reader, so if you're thinking about something, you have to say it out loud, and not just because you said it everybody heard. So that's when we are going for closed loop or 3 C's. So you should talk and see that the person heard. And it's not just because someone heard you that understood you. So the feedback should come and make clear, and that the person understood what you said, and understood is not done. So this is a way to summarize our closed loop communication. It's really, really important, and it's important for the best care for our patient. Also, there's a QR code for an online course from Columbia University. It's a free course really interesting course about CRM in medicine. I really recommend it, and I'll see you next time.